Good morning. My name is Khurram and you are watching Optometry with Khurram. And our today's topic is the PMT, the Post Mydriatic Test. And the name should be Post Cycloplegic Test, I think. Right? So, Post Mydriatic Test or Post Cycloplegic Test, we are nothing to do with. We have to learn the Post Mydriatic Test. We have to learn about this test. Right? First, we have to learn that what is actually the cycloplegia. Right? Then we will discuss that what is cycloplegic refraction, and then we will discuss that what is post mydriatic test or post cycloplegic test. So what is cycloplegia? The cycloplegia is actually a phenomena in which the ciliary muscles are get paralyzed. Right? You know very well, as name implies, that cycloplegia, cyclo mean the ciliary body or the ciliaris muscle, and plegia mean the paralysis. Right? It means that the ciliary body or the ciliaris muscle, more specifically the ciliaris muscle, is not working properly and the ciliaris muscle is paralyzed. So when the ciliaris muscle is paralyzed, and you know very well that the ciliaris muscles is totally concerned with the accommodation, the increase of the power of the crystalline lens. So when the paralysis of ciliaris muscle is there, the ciliaris muscles will not accommodate the lens. Right? The accommodation will be paralyzed, and when the accommodation will be paralyzed, this is called the cycloplegia. Right? And what is mydriasis or mydriatic eye? If the pupil is dilated from the optimum normal condition, right, normal size of the pupil, that is called the mydriasis. Right? So there are two different things, cycloplegia and mydriasis. In cycloplegia, accommodation will be relaxed due to paralysis of the ciliary muscles, right? And in mydriasis, the pupil will get dilated. Pupil will dilated. That is called mydriasis. So this is cycloplegia. And now we will discuss that what is actually the cycloplegic refraction. So cycloplegic refraction, right? We are talking about the clinical refraction, right? The cycloplegic refraction, it is a phenomena in which we treat the patient, the refractive errors of the patient, by putting the drugs inside the patient's eye. Like we have discussed about the drugs, right, to get the accurate number, right? You know very well, we perform cycloplegic refraction in under 15 children. We perform cycloplegic refraction. So in this specific age group, we perform the cycloplegic refraction. And what is cycloplegic refraction? You know very well about the cycloplegia. The accommodation should be relaxed, the ciliaris muscle should be paralyzed, right? But by putting the drugs, right, it's cycloplegic refraction. So we use specific type of drugs to relax the accommodation, to paralyze the ciliaris muscle, right? And what are these drugs? We have discussed in details in our last video, and the video is about the cycloplegic drugs, right? And what are those drugs? We have discussed about the atropine, we have discussed about the homatropine, we have discussed about the mydriacel or tropicamide, we have discussed about the very important, which is called the cyclopentolate or cyclopin, right? We have discussed about their you can say their mechanism, their definitions, their mechanism of actions, their indications, their contraindications, their dioptric allowance, right, and their duration as well. So we have a detailed video on our cycloplegic drugs. You can watch this video, the link is in the description, right? And but in this video specifically, we will discuss about the post mydriatic test. Suppose a patient came in our clinic with the complaints, a child of 1 year of age, 2 years of age, 5 years of age, 13 years of age, 14 years of age, or 15 years of age, any age group up to 15 years. So we have performed the cycloplegic refraction. We have put the drugs, we have instilled the drugs in his eyes. Remember one thing, that if the patient is of 1 to 3 or 4 age, the recommended eye drops, right, are the atropine. And if the age of the patient is more than 5 years, then the recommended drug is cyclopentolate or cyclopin. Remember this thing, this is important, right? So we have a child who visited your clinic with his or her parents, and you start cycloplegic refraction, and in cycloplegic refraction you instilled the cyclopin drops or cyclopentolate, right? And right now his or her pupil is dilated and ciliaris muscle is totally relaxed or paralyzed. So patient's pupil is dilated, one thing, and ciliaris muscle is paralyzed. Second thing, now our patient is ready to perform cycloplegic refraction. We took our retinoscope and get his or her prescription, right? So why we call the patient after 2 to 3 days? In case of cyclopentolate, we call the patient after 3 days, and in case of the atropine, if we use atropine as our cycloplegic drug, we call the patient after 1 month. Why? This video is about that why we call the patient after 1 month in atropine or after 3 days in cyclopentolate, right? So we will get the reason of this very important question. Actually, this question is $1 million question, right? So we will get the answer. You know very well that after putting the eye drops like cyclopentolate, like atropine, right, the pupil, first of all the pupil, you know very well this is the door of the eye. I always call the pupil as door of the eyeball. If you want to enter the eye, you have to open the door. Either the door is very closed or the door is widely open, right? So this is the pupil, the door of the eyeball. You have to open it, and we have opened it. We have instilled the eye drops like cyclopentolate or atropine, right? And our door is widely opened, right? The pupil is open, right? But you know very well, if the door of the eye, if the pupil of the eye is widely open, is widely dilated, then it can affect the visual acuity of the patient, right? So if the pupil is fully dilated after instilling the drops, after instilling the drugs, cyclopentolate or atropine, whatever, so the door is widely open or dilated, pupil is dilated, so it can affect the visual acuity. How? You know very well, to get the best visual acuity, to get the sharp visual acuity, the pupil should be optimal, the pupil should be at its optimal opening, right? The pupil should be at its normal opening. You know very well that the sharp focus will occur, the sharp focus, the depth of focus will increase if the pupil is constricted. The more the pupil will constricted, the visual acuity will get more and more sharp. You know, you remember the effect of the pinhole. Pinhole is like a small hole. So why we put pinhole when we use to increase the visual acuity of the patient, right? Because the pupil is so closed, the hole is so small, so that small hole can increase the depth of focus of the patient's eye, right? So when the pupil is dilated, I don't think, but I'm sure that the visual acuity of the patient will get decreased. So that's why at that time of the cycloplegic drugs, at that date, you perform the cycloplegic drugs. When patient is under the effects of the drug, you should not prescribe him, or you should not perform that PMT test, right? You should not perform that subjective refraction instantly after instilling the drops, right? So reason number first is pupil size. So pupil size is greater than the normal, so it's not the proper time for subjective refraction. Now another reason is depth of focus itself. We have already discussed that when the pupil is normally dilated, or when the pupil is at its normal position, the depth of focus is normal, right? And when the pupil is fully dilated, you know very well, the depth of focus will decrease, right? Depth of focus will decrease, as we have discussed already, that whenever the pupil is more constricted, right, the depth of focus will increase, as I have given the example of the pinhole, right? But if the pupil is dilated, then the depth of focus will get decreased. So if the depth of focus will get decreased, patient will be unable to read the chart properly, right? So this is reason number second. And now the reason number third, depth of field. So reason number third is depth of field. You know, depth of field, the visual field. As the pupil is constricted, the visual field will get decreased, and as the pupil will dilated, the depth of field will get increased, right? But we need, for the sharp visual acuity, we need a normal, optimal depth of field. So due to these three reasons, we should not perform the subjective refraction after the objective refraction, or the cycloplegic refraction, I must say, right? After instilling the drops that specific day, on the same day, the subjective refraction is not very helpful. It can be dangerous. It can be dangerous for the patient, right? And the fourth reason is side effects of drugs. You know very well, we have discussed about the side effects of the drugs, right? Like atropine, like cyclopentolate, like mydricel, like tropicamide. So every different drug has its own side effects. You know, after putting the cycloplegic drugs like cyclopentolate, patients could be get fever, patients will get sleepy, right, lazy, and at this lazy condition, or if you get fever, then your routine work is not normal, right? So that's why patients will face the side effects of the drugs. So he is already, or she is already facing the side effects, the physical or systemic side effects of the drugs. So that time is not proper, I think, for the subjective refraction, right? You know very well the contraindications, indications and contraindications and side effects of the cycloplegic drugs, right? We have discussed in the last video. The link is in the description. So due to those side effects, I think that specific day when you perform the cycloplegic drugs, when you perform the cycloplegic refraction, that specific day is not useful to perform the subjective refraction. So due to these four conditions, we call the patients at PMT. And what is PMT? PMT, Post Mydriatic Test. Post mean after, right? And mydriatic means dilation, right? And test mean test, or it also called, the appropriate word for this test is post cycloplegic test. So post mean after, cycloplegic mean the paralysis. Cyclo mean ciliary body, plegic mean paralysis, right? So after, the ciliary muscle will get paralyzed, and when the effect of this paralysis will get end, then we call the patient for the subjective refraction. So this is called the PMT, the Post Mydriatic Test. Now the things we are going to discuss right now are very important. You have to keep it in mind, right? These are very important. So we will discuss that what if the patient is hyperopic, we have to prescribe full correction or under correction, right? If the patient is myopic, we have to prescribe full correction or under correction. And if the patient is hyperopia associated with esotropia or exotropia, we have to prescribe full correction or under correction. And if the patient is myopic with esotropia or exotropia, we have to prescribe full correction or under correction. These are some confusions, right? So you have to be very careful. You have to listen very carefully about these concerns. So first we will discuss about the hypermetropias, just hypermetropia. So there are two schools of thoughts right now. The most important school of thought, the school of thought number one is, they say prescribe full correction. And the reason, we will discuss the reason that why we should prescribe full correction to the hyperopic patient. The reason is, as this is our eyeball, right? And patient is hyperopic, like light rays are behind the retina, and we have to put these light rays at the retina, on the sensitive layer of the eyeball, at the sensitive retina. So we have to prescribe full correction, the plus full correction. And when we will prescribe the full correction, the light rays will come on the retina, exactly on the retina, right? So The reason why we should prescribe the full correction, the reason behind that, the logic behind that is, in hyperopia, patient is accommodating, and when patient is accommodating, right, when patient is accommodating, you know very well about the ACA ratio, right? You know very well about the synkinetic near reflex. And what is synkinetic near reflex? The three different phenomena are occurs simultaneously, like accommodation, convergence, and pupil constriction, right? So we exclude for some time pupil constriction, we exclude pupil constriction. Two phenomena, like if accommodation occurs, convergence will occur. If one diopter of accommodation is there, three prism diopter of convergence would be there. So if the accommodation is of one diopter, then the eye will get three prism diopter of convergence, right? So to avoid the convergence, because over convergence is dangerous, over convergence is asthenopic, over accommodation is asthenopic, over accommodation is dangerous, is lethal, right? It can cause the asthenopic symptoms. So to avoid those asthenopic symptoms, we have to prescribe full correction in plus, right? So when we will prescribe the full correction, the light rays will get totally on the sensitive layer of the retina and accommodation will be relaxed. And when the accommodation will be relaxed, the convergence will be relaxed. There would not be any extra convergence on accommodation. So it will create a feasible and smooth and soothing effect for the eyes, right? So that's why we prescribe full correction in case of hypermetropia. But different researchers, different authors have different school of thought at this point. Some researchers or some authors says that you have to prescribe under correction in hypermetropia. I know this is very disturbing thing for you. So they will prescribe the under correction. I am telling you the reason, if I can satisfy you at this point, right? So under correction in case of hypermetropia, this is very strange. That was very strange for me as well when I read this, right? So I'm telling you the reason that why we should prescribe, why we prescribe actually the under correction in hyperopia. Listen, we are actually prescribing, we are actually doing, right, the subjective refraction. We are instilling the drops, and it means when patient is hyperopic and we instilling the cycloplegic drugs in the patient's eye, right? When the patient was hyperopic, the brain was working according to the patient's eye condition, right? Patient's eye was at deficiency of the plus power. The eyeball was facing the deficiency of the plus power because the hyperopia was there, right? And when brain know that my eye, my beloved eye is facing deficiency of the plus power, right? So the eye is sending his signals to accommodate. So the lens is properly accommodating to increase the power, right? To compensate the plus power which is deficient in the eyeball, right? So now brain actually giving the signals to increase the plus power because the eye is facing the deficiency of the plus power. So now the brain is habitual, the eye is habitual to increase the plus power. And when we call that patient for the cycloplegic refraction, and when we instill the cycloplegic drugs, and those cycloplegic drugs paralyze the accommodation, right? And then we prescribe him we prescribe him a full correction of plus power. After the cycloplegic refraction, we gain a plus power prescription and we prescribe him the full correction of the plus power. Now, as the brain is habitual, the eye is habitual to accommodate, right? And this habit will go slowly, not instantly, right? And as brain is sending the signals to accommodate, eye is itself increasing the plus power, and from the externally we have prescribing him plus power in the form of glasses, and now plus power is going increase and increase from the brain in the form of accommodation and from the glasses in form of glasses. So plus power is increasing from the both sides. Then patient will face severe intolerance of the glasses because the child is a baby or child is of 3 years of age, 4 years of age, 5 years of age, and when he will put the glasses, and if he feel any symptom, if he feel any complaint like headache, watery eye, something, any asthenopic symptoms, because the power is increasing from the both sides, from the brain in the form of accommodation and from external side in the form of glasses. So both sides are increasing the plus power. So when both sides plus power is increasing, that will cause a severe intolerance of the glasses for the patient, right? And we can destroy the habit of the patient to wear the glasses. He will not wear glasses in the future, right? So that's why this is the reason. Some author says due to this intolerance of the glasses for the baby, we have to prescribe minimum plus, and then we have to increase it gradually, progressively, right? So this is two school of thoughts regarding the hyperopia. So this is the reason that why we should prescribe minimum plus in hyperopic. You can prescribe maximum plus. I have told you the reason. We have prescribed minimum plus in hyperopia. I have told you the reason, the logic. So it's your choice to that. This is up to your practice that you prescribe the maximum plus in hyperopia or minimum plus in hyperopia. This is your choice. I'm a teacher. I have to told you the two main perspectives, two main reasons behind these two theories, right? And now we will discuss that why we should prescribe minimum minus in myopia, or why we should prescribe maximum minus in myopia. Now what we should do in case of myopia. So we have a myopic patient, right? And there are two school of thoughts as well in case of myopia, right? So someone says, as we all know, that we should prescribe minimum minus. We have to prescribe minimum minus in case of myopia, right? Why we should prescribe minimum minus in case of myopia? You know very well. Minimum minus mean if this is our eyeball and this is myopic eye, as you know that light rays are in front of the retina, and the first school of thought is that we have to prescribe minimum minus. So we have corrected maximum myopia, but we left some residual myopia in the patient. Why? Because if we fully correct it, if the patient is a slightly myopic, like the patient total myopia was about minus 2.25 for example, but we prescribe him minus 2, so there is minus 0.25 myopia is there in the eyeball. So you know very well that if the patient eye is myopic, then it is impossible for that eye to accommodate. So our main concern when we are prescribing the prescription, our main concern is to relax the accommodation, not initiate the accommodation, right? So if the patient is slightly myopic, then there is no reason for the eye to accommodate. So that's why we prescribe minimum minus in the patient's eye. And now we will discuss, you are going to kill me, right? So now we are discuss that why in myopia we should prescribe the maximum, or you can say the full correction of myopia. I will tell you the reason, right? The reason is a research is there that if you prescribe minimum minus or if you prescribe under correction in some patients, but this condition varies patient to patient, right? So a second school of thought is if you prescribe minimum minus or under correction in minus, right, then you can initiate the provision of the myopia. It can increase the myopia, it can make the myopia progress, right? So this is a school of thought, right? So there are two different school of thought in myopia. First is we have to prescribe minimum minus. I have told you the reason. Second is maximum, not maximum, or you can say full correction, right? Why full correction? Because the school of thought is, say some authors, some researchers says that if you prescribe under correction in myopia, then it can lead the progressive myopia, not progressive myopia, it can progress the myopia, the most suitable word, right? So it can progress the myopia. So that's why we should prescribe minimum minus, right? So we have discussed about the different school of thoughts regarding the myopia and hypermetropia, right? About the full correction or under correction, right? And now we will discuss that why we should prescribe or what we should prescribe if the squint is associated with the refractive errors, right? If the hyperopia, if the patient is hyperopic and associated squint is esotropia or exotropia, then what we should do? So the patient is hyperopic again, and associated squint is, what if esotropia is there, and what if exo is there? So in case of hypermetropia, patient is specifically hyperopic and associated squint, if the associated squint is esotropia, what we should do, right? So in this case, you have to prescribe full correction. I have told you the reason before, right, earlier. So in hyperopic patient, esotropia is there. If esotropia is there, you have to prescribe full correction, because if you prescribe full correction, the full correction will relax the accommodation. The accommodation will be relaxed, then relaxed accommodation will relax the convergence, and if the convergence is relaxed, we can treat, we can manage our esotropia. Simple, right? Now, in case of, if the patient is hyperopic and exotropia is there, contrast, opposite, under correction. So in exotropia, we have to prescribe under corrected plus power, right? Why? Suppose this is eyeball, patient has hyperopia, and we will under correct the plus power. So we are not going to treat the whole hypermetropia. We left some hyperopic condition in the eyeball. So we left some hyperopic condition in the eyeball means patient will accommodate, because if the patient is hyperopic, the hyperopic eye will definitely perform accommodation, and when the patient perform accommodation, accommodation will initiate convergence, right? Accommodation will initiate convergence. Patient is exotropic, right? And when accommodation is there, the eyeball will move inside, right? Because the accommodation is there, and if the accommodation is there, convergence would be there, and this convergence can treat or manage the exotropia. So that's why in case of hyperopic patient, and if the exotropia is there, we have to prescribe under corrected plus power. And now we will discuss about myopia. If the patient is myopic and associated squint with myopia is esotropia, right? So we have to prescribe under correction, under corrected minus, right? Patient is already myopic. If the patient is already myopic, he is not going to accommodate. The myopic eye can never accommodate, right? So we have to prescribe under corrected. Under corrected myopic means we are not going to treat the whole myopia. If the myopia is of minus 2.25, as I have discussed in few minutes back, if the myopia is of minus 2.25, we have to prescribe him minus 2. So it means minus 0.25 myopia is there, still there. So if myopia is still there in the eyeball after correction, myopia is still there. I say myopia is still there, and if the myopia is still there, and as I have said that myopic eye can never accommodate, right? And if the eyes can never accommodate, the convergence will never occur, and if the convergence is never occur, it can help in esotropia, right? Simple. And if the patient is myopic and the condition is exotropia, right? So we have to prescribe full correction. Simple. Full correction, why? Exotropia, right? So if you prescribe full correction, myopia was there, the light rays are here, and when we will prescribe full correction, you know very well, if you prescribe full correction, we are not sure, because if the patient is myopia and if you are increasing the minus power, because the myopia is of minus 2 suppose, or you can say the myopia was of 2.25. So we prescribe -1, patient says very good. We prescribe -1.5, patient says very good. If we prescribe -2, patient says really very good, right? And if we increase the power, suppose we are going to -2.25, then we will go -2.50. As we are increasing the minus power, patient will appreciate. As we are increasing the minus power, the size of the object will get decreased, but the contrast, but the acuity of that object, of that optotype will increasing. So here it is difficult for patient and it is difficult for clinician or optometrist. For both of them, it is difficult to evaluate that what is actually the exact myopic power of that patient. This is the biggest mistake in the cycloplegic refraction, or you can say in the subjective refraction appropriately, right? So as patient is encouraging you to increase the minus power, suppose mistakenly you prescribe him full correction, and in the case of full correction, in the form of full correction, you gave him maximum minus power. So in case of full correction or over correction of the minus, the eye of that patient would be hyperopic, and you know very well that hyperopic eye can accommodate. And when eye will accommodate, right, you prescribe full correction or you prescribe mistakenly over correction to the myopic patient. I have told you the reason. And when you prescribe the over correction of the minus, you know very well the over correction of the minus will lead to hyperopia, right? So right now the patient is hyperopic, slightly hyperopic, hyperopia of just -0.25. So if the 0.25 of hyperopia is there, actually the eye was myopic. We prescribe maximum minus or over correction of the minus, then the eye will convert into hyperopic, slightly hyperopic, and hyperopic eye can easily accommodate. And when accommodation is there, convergence would be there, and our eye is exotropia. So that convergence can treat or manage the exotropia. So that was all about the PMT and the correction after the PMT, right? What we have to prescribe after the post mydriatic or post cycloplegic drugs, right? I hope you understand. I hope the all concepts regarding the PMT, the post mydriatic test, are clear. We'll see you in the next video.